two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 94. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Hi, good evening, Swapnil. Good evening, everyone.
Yeah, it has been a while we have recorded our last episode. Obviously, there were a few important things that we both were busy with. Having said that, now it's good to be back. And first and foremost, how the situation overall in India, and you just came from conference. So how was the conference?
Yeah, the conference was a bit of a disappointment in the numbers we actually had. It was much less attended than what we would have hoped to, particularly after such a long break. But overall, the academic sessions were of pretty good quality. And I think those who were there would have really gained a lot of information from the deliberations.
Yeah, that's right. I guess we are now used to this online platform so much that attending the conference in physical space might become an issue in future. We are organizing the conference in April here through ANZIX. We have got now 800 registrations. So not too bad, but I guess overall we can see that change in thinking process of audience, that if you can get a content when you're at home, why to travel all the way to different country or different cities, I guess.
Entirely true, yes. People would think, if you can do what you're doing online without the hassle of travel, why go through all that? I suppose that could be the reason why our attendance was not up to the expected level as well.
Yeah. And I guess now most of the time we are delivering this content online in different formats. And even this podcast is part of that kind of process where we discuss a lot of trials, journal articles, which obviously help audience to sit at home or even listen while they're driving the car, for example. So today we have decided to do another journal club, and the trial that we have chosen today is the trial which was recently published in JAMA, which came from Prague out of hospital cardiac arrest study group. And this trial is really fascinating, interesting, and also will be considered as a landmark trial in this topic of eCPR, or extracorporeal cardiopulmonary resuscitation in patients with out-of-hospital cardiac arrest. So just to give a little bit of background, out-of-hospital cardiac arrest still remains a significant socio-economic burden to society, but also to intensive care, because almost 50% of the patients who achieve ROSC during initial resuscitation and then transferred to hospital for post-resuscitation care achieve favorable neurological survival. So 1 in 2 patients die despite achieving the ROSC, and only 1 in 2 patients manage to achieve the meaningful neurological recovery. And that mortality has not changed over the period of time, despite the advent of different technology or the overall improvement in the standards of intensive care across the world. Now, when we look at what can be done to improve the survival of patients with out-of-hospital cardiac arrest, one of the thought which was put forward was whether we can use invasive strategies early, such as putting the patient on VA ECMO while the CPR is still going on. And there is not a lot of data on this topic. And there was one very small randomized controlled trial, which was published before, called an ARREST study, which showed that there might be a benefit of putting patients on ECMO during CPR in patients who had a shockable rhythm. Obviously, there were a lot of issues with this study. It was grossly underpowered. And after the ARREST study, the different parts of the world started doing eCPR studies. And in most of the parts of the world, currently, there are some of the trials are still ongoing. And I must say that it has been quite a significant learning curve, even in developed countries, to perform eCPR. Clearly, very resource-intensive method. And obviously, the outcomes are still not proven to be great, right? People have got used to performing eCPR. So the question that this trial was really asking was, In patients with witnessed refractory out of hospital cardiac arrest, does early intra-arrest transport, extracorporeal cardiopulmonary resuscitation or eCPR, and invasive assessment and treatment improve outcomes compared with the standard resuscitation? So, Dr. Chaco, can you please walk us through the methodology and the trial results, please?
Yeah, Swapnil, to answer the question that you just raised, the study was conducted in the Prague region over a 7.5-year period between 2013 to 2020. It was a single center, randomized controlled trial. Patients who were between 18 to 65 years old and who were receiving ongoing resuscitation for witnessed out-of-hospital cardiac arrest of presumed cardiac etiology were eligible for inclusion into the study. And they had to have a minimum of 5 minutes of advanced cardiac life support without attaining return of spontaneous circulation. The randomization was stratified into 4 strata: men or women aged 45 years or higher versus less than 45 years, and it was in block sizes of 8. They excluded patients who had unwitnessed cardiac arrest or who presumably had a non-cardiac origin as the underlying cause. Those who attained ROS within 5 minutes of resuscitation were excluded. Patients who regained consciousness in between were excluded. They also excluded patients with life-limiting comorbidities, those who had bleeding diathesis, who had a do not resuscitate order, patients who had a pre-arrest cerebral performance category score of 3 or higher, meaning a poor neurological status, were excluded. Pregnant women or a likelihood of pregnancy was also an exclusion criterion. So in the intervention arm, patients were transferred early intra-arrest to the hospital using a mechanical CPR device. Locus was what they used. And these patients were directly taken to the cath lab with commencement of eCPR if ROS was not achieved in transit. All other interventions were according to the European Resuscitation Council guidelines. eCPR, ECMO, was instituted using a FEM approach. During the initial phase of the study, they also used intra-arrest nasal evaporative cooling using a special device. This was later on stopped during the course of the trial. And they performed angiographic intervention as quickly as possible. And based on the angiography findings, they would carry out interventions as deemed appropriate. In the control group, standard resuscitation interventions were followed. Transport to hospital was carried out if ROS was achieved. They also underwent early angiography and appropriate intervention. They could also have a mechanical device for CPR. As I mentioned, during the early phase of the study, they used hypothermia to cool their patients down to 33 degrees centigrade. But then halfway through the study, the TTM trial was published, and then they changed their temperature strategy to 36 degrees. All other care were according to the European Resuscitation Council guidelines. Crossover was allowed from the standard arm to the invasive arm or the eCPR arm if it was specifically requested by the emergency physician. But for that, at least 2 unsuccessful defibrillation attempts had to be present for crossover from the standard to the invasive arm with eCPR. And crossover from invasive to standard was carried out if it was considered futile to press on with invasive interventions. How did they calculate the sample size? 3 sample sizes were calculated for a two-tailed alpha of 0.05 and 90% power. 10% difference in the primary outcome would include 571. 15% difference in the primary outcome would include 285. And 20% difference in the primary outcome would mean a sample size of 176 patients. So they screened 4,345 patients who suffered out-of-hospital cardiac arrest for eligibility. A large number, nearly 4,000, were excluded for various reasons. 358 subjects without return of spontaneous circulation were assessed for inclusion, out of which 94 were excluded for various reasons. 264 patients were randomized finally to the invasive or the standard arm. 124 patients were randomized to the control group and 132 patients to the invasive arm. And the analysis was based on intention to treat regardless of crossover. As I mentioned, they could cross over from one arm to the other. In fact, 9 crossed over from invasive to standard. The study was terminated after inclusion of 256 patients for futility based on the recommendation of the Data and Safety Board. So if you look at the whole cohort, acute coronary syndrome was the underlying cause of the arrest in roughly 50% of all subjects. Pulmonary embolism was the underlying cause in about 10%. Myocarditis was the problem in 5% of the invasive intervention group versus 2% of the standard group. Ventricular fibrillation was by and large the most common rhythm, 58% in the invasive versus 64% in the standard arm. The median pH was 6.93 versus 7.03 invasive versus standard. The median lactate level was high, 12.5 versus 10.4. Angiography was carried out in 98% of the invasive arm versus 77% in the standard arm, and most of these were coronary angiograms. A successful PCI was possible in 90% of those who underwent angiography in the invasive arm versus 80% in the standard arm. So what were the outcomes that they looked at? The primary outcome was survival to a cerebral performance category score of 1 or 2. CPC-1 is the ability to work independently. CPC-2 is ability to work in a sheltered environment. So survival at 180 days at a CPC score of 1 or 2, meaning a good neurological outcome. So this occurred in 39 out of 124 patients in the invasive arm versus 29 of 132 patients in the standard arm. It was 31.5% invasive arm versus 22% standard arm. So this difference was not statistically significant. Odds ratio of 1.63, 95% confidence interval 0.93 to 2.85 included 1, and the p-value was 0.09. So the primary outcome of survival at 180 days with a good neurological outcome, meaning CPC score of 1 or 2, was not significantly different between the invasive or the eCPR group versus the standard group. They looked at several secondary outcomes as well. Survival to 30 days with no requirement pharmacological or mechanical cardiac support was not different between the two groups. 43.5% in the invasive arm versus 34.1%. Although the difference was numerically in favor of the invasive strategy, the difference fell short of statistical significance. They also looked at neurological recovery with CPC 1 or 2 during the first 30 days. Remember, the primary outcome was 180 days. This was the first 30 days. And when they looked at the neurological recovery to CPC 1 or 2 in the first 30 days, it was significantly in favor of the invasive arm, 30.6% versus 18.2%. But as I mentioned, this difference faded out over time with a few patients in the standard arm also recovering to the CPC score of 1 or 2. So the difference ceased to be significant at 180 days, although it was significantly in favor of the invasive arm at 30 days. They also analyzed post-hoc subgroups of patients for survival at 180 days with CPC of 1 or 2, 65 years or more versus less, based on gender, location of arrest, the initial rhythm, pH above or below the median value, lactate level above or below the median value, and the underlying cause of the cardiac arrest. These were not different between the two groups. They looked at adverse events as well. Bleeding complications, as you would expect. For more common with the invasive arm, any bleed was 31% in the invasive arm versus 15% in the standard arm. Fatal bleed occurred in 11% versus 0% invasive versus standard. Intracranial bleed occurred in 22% of invasive patients versus 20% of standard care. So essentially, this study showed that survival to a good neurological outcome was the same between patients who had an invasive approach with eCPR compared to the standard approach. That was the primary outcome. The survival without any requirement for pharmacological or mechanical support was also not different between the two groups. Post hoc analysis of subgroups of patients based on age, gender, location of the arrest, initial rhythm, and so on were also not significantly different between the two groups.
Thanks, Dr. Chakos. So I guess this study is quite interesting and important because this is probably the first largest randomized controlled trial on this topic. Now, we have a couple of centers in Sydney who started performing eCPR, and the anecdotal experience is not that encouraging. But I must say, I heard some of the stories where the outcome for the patient was great. So there are always, some exceptions that obviously the eCPR is not completely useless intervention, or it is always going to be harmful intervention. So there are always some of the good survival stories of eCPR. Having said that, when you put this intervention in one basket and then try to randomize patients and try to see whether this intervention is going to be effective for all patients who have suffered from out-of-hospital cardiac arrest, then I think the answer is going to be probably it's not going to be effective. And I think that's why the selection of the patient becomes very, very important when you are evaluating the effect of this particular intervention. And that's why I think there are some of the key things to point out in early tables. So first and foremost is the incidence of shockable versus non-shockable rhythm. Now, we know from the previous literature that eCPR is going to be most effective in patients who had shockable rhythm at the time of cardiac arrest. In this trial, invasive strategy had 25% of the patient who had asystole compared to 18% in standard strategy. The second important finding is around the duration of the CPR. And I guess that concerns me to some extent. And that could be just because of the logistical challenge of putting the patient on VA mode or performing the eCPR. Is overall percentage of the patients who had more than 45 minutes of duration of CPR was significantly higher in invasive strategy group compared to standard strategy group, 73% versus 55%. And only 27% patient had a sustained ROSC on hospital admission in invasive strategy compared to 44% in standard strategy. And that means only 1/3 patients who actually receive eCPR on site managed to reach to hospital. And out of that 1/3 of patients, majority of the patients, or at least 3/4 of the patients, already had a CPR for more than 45 minutes. And out of all those patients, 25% had actually asystole to start with. So if you put these facts together, it was not surprising to see that patients in invasive strategy did pretty badly, or the overall there was no difference in outcomes, or the survival was meaningful recovery or meaningful survival was less in patients who received invasive strategy compared to standard strategy. So obviously, the understanding the context or putting these results of this trial in a kind of perspective is important. There are obviously some of the other important findings to notice in these tables include that targeted temperature management was much easy to follow in invasive strategy compared to standard strategy, because obviously with VA ECMO temperature management is much easier. Although the majority of the patients had acute coronary syndrome as a primary cause of cardiac arrest, only 90% patient had a successful PCI in invasive strategy group versus 80% in standard strategy group. So obviously that will automatically kind of add to that extra mortality, because if the underlying cause is not fixed, the likelihood of benefit is going to be less. Now, the interesting finding is, how do you then justify continuing eCPR? And I guess when we interpret the results of this trial, we have to interpret with a bit of pinch of salt. First and foremost is congratulations to author for actually performing the randomized controlled trial on this topic, because enrolling the patients and actually collecting the data and kind of finishing the trial is quite challenging in this particular topic. So authors did a great job. And incidence of brain death was obviously more in patient with invasive strategy. So 25% of the patients on who received eCPR become brain dead compared to 9% in standard strategy. And the flow-on effect of this was more patients were eligible or ended up in participating in donating organs, which is a huge challenge at the moment, because if the patients who suffer from out of hospital cardiac arrest, even their neurological recovery is poor, or majority of patients die in either before arrival of the hospital or they die in hospital, they don't progress to brain death and they don't end up in becoming organ donor. While patients who received invasive strategy, they ended up in become organ donor. So there are some pros with regards to eCPR. Having said that, based on the current results, I think is one might have to question the resource intensive nature of this intervention, and whether it is even feasible, or whether every center should be gearing up to perform this intervention in their hospitals. And I think that's a major question for developed countries, that whether high volume centers might do better job in performing these interventions. And I think that the second important message is the patient selection is really, really crucial while analyzing this intervention, which was probably not the case in this trial. But I guess that's the kind of key take home message for me. What's your initial thoughts, Dr. Jacko?
Certainly, yes. The concept of mechanical support during CPR, of course, is a very attractive concept. And if only you could execute it in an effective and efficient manner, would you probably generate good clinical outcomes. This study has shown a trend towards better outcomes. But I'm sure over time, with evolution of technology and the speed with which you can institute mechanical CPR, we are probably likely to get much better results than what we see in this study. So over time, the technology of eCPR, of course, has improved over time. ECMO technology has also improved over time, and you would expect it to reach a higher level of sophistication in the future to allow for early institution of extracorporeal support. And that probably is the key towards improving the survival as well. And I think the authors of this study, they do deserve to be congratulated on carrying out a very difficult study to begin with of out-of-hospital cardiac arrest patients, randomizing them, transferring them to hospital without delay, and then institution of ECMO, by no means an easy task to do. And they did this over a very long period of time, more than 7 years. So they really deserve to be congratulated for this trial. And some of the other points that evinces interest in this study is the 90% bystander CPR rate, which is pretty good in Prague. That's pretty good. I really hope that we could emulate something close to that in India, which is certainly something to hope for. The weaknesses of the study would include being a single center study. It will not, of course, be applicable to a broad subgroup of patients. And when it comes to ECMO and eCPR, experience, of course, will be the key, because if you are a center that constantly deals with patients like this, you will generate much better results than if you come across patients only once in a while. There was some change in management during the course of this study, including the use of hypothermia during the early phase, which was not done during the latter phase of the study. And the study itself may have been underpowered when it was ceased for futility, largely because the survival was higher than expected in the standard care group. So that may have reduced the sample size and may have resulted in an underpowered study. And of course, they were allowed to cross over from one arm to the other. Although it was based on intention to treat, still the crossover may have biased results as well. So overall, this is a good study. It could be a forerunner of a more sophisticated and more effective eCPR management of patients with out-of-hospital cardiac arrest.
Thanks, Dr. Chakos. So I guess I agree with all the limitations, I guess, that you mentioned. And I guess even though generalizability might be a problem with single center design, I guess overall eCPR has become quite standardized process in most of the hospitals, and I guess centers that are performing eCPR regularly, as you said, have got better in performing those interventions. And some of the good outcomes that I have heard from my colleagues here in Sydney are those young patients, shockable with them, predominantly coronary event, managed to get to cath lab, opened up coronary, and obviously they get better and they come off ECMO, so achieve a good neurological outcome down the lane. So I guess that's the kind of cohort of patients will definitely benefit from eCPR. The moment you try to stretch the boundaries or try to include all kind of patients in and offer this intervention to every single patient with out of hospital cardiac arrest, then obviously you start seeing some of the bad outcomes. And obviously, the important thing to keep in mind is this is by no means a very simple or harmless intervention. Obviously, it has been shown that the rate of complications are way more with this particular intervention compared to standard strategy. So I guess this study is definitely encouraging in a way that it showed us that one size fits all approach will not work with eCPR intervention. Having said that, from some of the data that we have gathered from this study, will probably force us to think hard in future to select our patients carefully and wisely, but also not to write off this intervention completely. Because as you rightly mentioned, the more experience we get with this intervention, we will definitely get better in this intervention. And obviously we will be able to improve the survival rates in this cohort of patients. Any final thoughts, Dr. Chakra?
Yes, Swapnil, we, of course, in India, we don't do this eCPR for hospital patients with cardiac arrest. So it is something perhaps that we should look at as well. Our ambulance systems are much more efficient than what they were a few years ago. So this is, again, one of the options that you have, particularly, as you mentioned, in younger subjects with coronary artery disease as the underlying problem who suffer out of hospital cardiac arrest, whether they would have better outcomes with eCPR is something that perhaps would evince interest in India as well.
Yeah, that's correct. And I guess we won't know until this intervention has been tried and tested truly in different parts of the world and different cohorts of the patient. So obviously, I guess the word of caution for naysayers that based on this negative study, quote unquote, don't write off this intervention yet. So that's probably the conclusion of this podcast. So thanks, Dr. Chakra, for your time. We'll be back in a week's time with another episode. Till then, goodbye and have a nice time. And happy Easter.
Thanks, Swapnil. Thanks, everyone, for listening in. Happy Easter to everyone. See you next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.